Good morning, everyone. Welcome to the CMSS spring meeting. We're delighted to have you again virtually, but hopefully next year in person. On behalf of Darrell Moyer, the ACP, EVP, and CEO, and the current president of CMSS, we want to welcome you to this opening plenary session for our meeting on COVID-19 and beyond. We're delighted to have some great speakers who will be joining us shortly. So let's just go to the next slide if we can. Just a reminder, these are the 45 societies that make up CMSS, really covering the entire house of medicine from primary care to surgery and everything in between. So really pleased we have this chance to share this with all of you. Next slide. So this morning, we're delighted to be joined by two speakers, Dr. Marcella Nunez-Smith, who many of you are probably aware is the chair of the HHS COVID-19 Equity Task Force. She's also an associate professor of medicine, public health, and management at Yale, and the associate dean of health equity research at Yale. Also joined with us again, for most of you who were probably with us last spring, is another visit from Dr. Ashish Jha, who has changed jobs since the last time we saw him, and he is now the dean of the Brown University School of Public Health, professor of health sciences, policy, and practice, formerly director of the Harvard Global Health Institute. Really delighted to have them with us. Just a couple of housekeeping slides and we will launch. Next one, please. Just since it is, this is a webinar function, please go ahead and use the chat, the Q&A, and the raised hand feature to ask any questions and stay engaged. Next slide. And then finally, we will have PowerPoints for later sessions available, and recordings will be available on demand as well for all of our registered attendees. So with that, let's get started. I'm really delighted that first Dr. Marcella Nunez-Smith, who only has a short time with us in her very busy HHS role, will join us. We shared some questions with her in advance. So please, Marcella, we'd love your thoughts and comments for this group, particularly around COVID-19, as well as vaccination and the issues around equity, and particularly what specialty societies can help with in this space.
Well, thank you so much. It's just a great pleasure to be here this morning. And of course, considering myself a member of our great family of medicine, just wonderful to be with all the colleagues and a moment to just express gratitude for everybody's leadership, commitment, and hard work over this past period. So, you know, the group asked me to think a little bit about kind of where we are with thinking about equity in COVID-19 specific to data and our data infrastructure. So I'll talk a bit about that as well as give maybe an overview of the task force. We're really excited to be launched. And then, of course, just a few minutes to talk about what specialty societies can do. So, you know, as was mentioned up top, it's a deep honor for me to serve as chair of the COVID-19 Health Equity Task Force that is based at HHS. You know, we are very fortunate to have for our work a blueprint. The vice president proposed this task force when she was still a senator, and now by executive order, the president brought the task force into being on his first full day. You know, we have gathered together just a tremendous complement of members for the task force. We have 12 non-US government representatives really representing the diversity of the communities across our country, both in terms of geography, but also in terms of kind of those who have been left behind in the pandemic. In addition to those members, we have the pleasure of welcoming several US government members as well, with many agencies represented on that task force. We have a very ambitious agenda. Our work is set forward in that same executive order I just referenced, really thinking about how we mitigate. I mean, everyone is fully aware that COVID-19 did not create the inequities and disparities that we witnessed, that what we see is an exacerbation. We have long-standing systemic inequity in our country across many of our systems, including in health and healthcare, but certainly not limited. I know top of mind for many of us, of course, in the criminal justice system, as well as in our education system, our system of housing, and the list goes on. So we're really happy to have this group that has both US government representation as well as non-US government representation to think about how we now mitigate disparities in our recovery to COVID-19, but also looking ahead to our resilience in our recovery and how we can make sure that we put in place policy that prevents this, what is always a very predictable pattern of who is most affected, in terms of disparity and inequity when we have moments of national crisis like this moving forward. So the work of the task force has launched. We have had 2 publicly facing meetings. Definitely want to invite everyone to engage with that work. We had in our last meeting focused on equitable vaccine access and acceptance, a chance for the group to present interim recommendations to everyone. And so that is all publicly facing. We also invite public comment every month. Certainly at the foundation of our work, though, is data. And so I'll make a special plea to say that there's no way for us to have a data-driven response and recovery if we don't have high quality and complete equity data. And so whether we talk about race, ethnicity as one of the important variables, or we take a more comprehensive look and consider things like social structural determinants. We know race plays, but so much more. You know, people who are disability status is certainly something that we know we have limited data and windows on, but yet groups are extremely affected. Everyone here I know understands intersectionality and the importance of thinking about the multiple identities that we all live with and how that might affect our access to health and healthy outcomes. And so really important for us to build, that's part of our charge, is building the data infrastructure necessary to drive equity across the whole of government. And so we are always anxious and open to input and feedback on that as we think about data systems. I know many experts in the audience today on that front, but also I think just a moment to once again lift up and call for us all to commit ourselves to the data collection reporting that is necessary for us to be able to use data in the way we need to drive equity. And then importantly, kind of the role of specialty societies. I think, you know, just to briefly say I think kind of 2 points I'd probably want to make at the top. So one is in the urgency of our moment now as we rush, we are quite optimistic that we have at this moment increased vaccine supply, and that is great. And that everybody who is an adult in our country is now eligible for vaccination. Also very optimistic, even as we know we need to stay vigilant a bit longer. But at the bottom, you know, no matter who we're talking about, when we talk about vaccine confidence and building vaccine confidence, every single demographic and constituent says that their most trusted messenger is the clinician that they know, right? Their provider. And that is all of us. And so I say thank you to everybody here for being that trusted messenger, for bringing to all of the many sort of patients and constituents this need, this urgency. And so many of the organizations here have been at the forefront of providing really tremendous resources and materials to individual providers, as well as to the general public. And so that is just vital as we move forward. You know, the other thing I would say for specialty societies now, you know, I harken back to data, but certainly thinking about our next generation. I know for me, this is what is most inspirational. I had a chance to meet with a group of college students in a town hall. So it was very, I felt the energy even across the Zoom format with those young folks. And I think it's all of our collective obligation as we recommit, really, this is not new for any of us here, but as we recommit to equity and health equity, that we think and invest very intentionally in that next generation, right? Making sure that we are recruiting into all of our ranks representative members, right? That we're working hard on diversifying our workforce, strengthening our leadership pipelines for that representation and inclusion, and really thinking about our policies and structures and the ways in which we have really just great, tremendous opportunity now to address and remedy, quite frankly, long-standing inequities. We know it's not easy, but I'm so grateful to be in this work with everybody who's here today.
Wonderful. Thank you so much, Marcella. That was wonderful. And we actually have a leadership summit tomorrow evening on equity and anti-racism. So this is perfectly timed. And I know you've got to scoot, so I just want to see if Darylyn wants to say any quick passing words before you leave, and we'll pass the baton on to Ashish.
I
Darylyn?
just want to thank you for the heavy lift that you're doing, and to remind everyone that there's no vaccine for racism, and now is the time to eradicate the structural inequities in our healthcare system. So thank you so very much for the heavy lift you and others are doing.
Thank you, everybody. Be well.
Thank you, Marcella. Really appreciate it. All right, Dr. Jha. Thank you again for joining us. What a treat to have you back. Unfortunately, we're still in a boat we don't think we thought we'd be in a year later. We've all had the great pleasure of listening to you, reading you in various outlets, including for me on NPR this morning as I was driving into work. So we'd love to just have you give whatever sort of opening remarks you think would be helpful in terms of your perspective about where we are, where you think we're going, and then we've got some time with our folks for some Q&A. So please, Ashish.
Great. Thank you, Helen, for having me back, and everybody for having me back. And really important conversation we just heard from Dr. Nunez-Smith, and the issue of equity has been something that's been pretty central throughout this whole pandemic, from who's gotten infected, who's gotten the right care, to now who's getting the vaccines. And I will build a little bit on some of the comments that Dr. Nunez-Smith made, but I want to start off by just reflecting on the moment we are in. And it's hard to know how to describe it in some ways. Limbo feels about right for the United States, worried about the global picture, and always remembering that America is part of the globe. And so you can't look at what's happening around the world and not reflect on how it's going to affect America. So let me unpack those things a little bit. Why limbo? So if you look at the last 2 months of new infections per day, it's pretty steady. On February 20th, we had about 70,000 new infections. Yesterday, we had about 68,000 new infections. Dipped a little, went back up, and it's starting to dip again. But it's basically been between 55 and 70,000 infections a day. It's the longest that we have been in a flat period. Usually, we tend to go up, come down, flatten for a little bit, and then kind of go back up again. That's been the course of this pandemic. So we've had a 2-month period of a plateau. And it's really unusual, but it actually misses a very important underlying point, which is there are 2 pandemics happening in the United States, or 2 ways to think about what's happening with the pandemic in the United States. On one hand, the pandemic for older Americans is largely over. It is, the vaccinations among people over 65 is extraordinary. A vast majority of people over 65 have gotten vaccinated. I don't want to overstate it by saying it's completely over. There are obviously still people over 65 who have not been vaccinated, but the numbers are really stunning. And what that means is we've seen infection numbers drop dramatically in this population. We've seen hospitalizations and deaths come down a lot in people over 65. And that's fabulous. And that obviously was the highest risk group. And so targeting older people for vaccinations was exactly the right idea. And it made an enormous difference. But there's a problem, which is the same time that we were doing these vaccinations, we've gotten hit by B117, the variant from the UK, and it is just wreaking havoc on people who are unvaccinated. I don't think there's ever been a more dangerous time to be unvaccinated in America during this entire pandemic. If you are unvaccinated right now, your chances of getting infected are really quite bad in terms of what is happening with a shrinking pool of unvaccinated people, and yet infection numbers staying very, very high. And if you think about that, it's a very precarious moment. And that means we've seen hospitalizations go up in people in their 30s and 40s and 50s. We've seen deaths go up in that population. And so we really have 2 different phenomena. And when you look at the national picture, it sort of feels like it's canceling each other out. And again, I'm very thankful for the progress we've made on older Americans and protecting them. They obviously they were the ones who really were hurt so disproportionately in much of the pandemic. So I don't want to take away from the good news. The good news is real, but I also don't want us to think that somehow this is all over. You know, we are at about 51, 52% of American adults having been vaccinated. And in terms of thinking about the vaccine, and then I'm going to talk a little bit about the global picture in a second, but in terms of thinking about vaccinations, one of the things I'm really worried about is our misunderstanding of who has not been vaccinated. And let me walk you through it as I have seen it from the survey data and really doing and looking at results of focus groups. And then I want to talk about the role of physicians in all of this, because I think it's going to be really important. We are going to be on the front lines of figuring out whether this pandemic gets under control or not. You know, I think about the group that's already been vaccinated as the like vaccine avid people. I mean, actually people like me who the moment that the hospital where I have my appointment like made it available, I was there, right? I was like signing up. The people who stay up all night for the new iPhone, the people who wake up at 4 a.m. and refresh their browser so they can get a vaccine appointment. That's a large chunk of America, and almost all of those people have gotten their first shot. That's 50% in my mind of people who are super vaccine avid. And in some ways, they're the easiest group to meet and serve because you just have to set up opportunities for them and they will find their way to the vaccine site. That's terrific. I'm really glad we've got that group. There may be a few out there who are still trying and struggling, but in state after state, vaccine availability has just exploded in the last week. Rhode Island, which was a state where there were lots of problems with like, again, a lot of vaccine avid people. Yesterday at the Dunkin' Donuts Center, of course, for those of you who are not from the Northeast, you will appreciate it. Of course, we have a Dunkin' Donuts Center in Rhode Island. But we had hundreds and hundreds of appointments available. At 10 in the morning, I looked and there were hundreds of appointments available in the afternoon. So the supply is now greater than the demand. But we can't look at the rest of adults and say, hesitancy. I think that's a complete misreading of the situation. When I look at the 50% that's left, 45, 50% of adults who are left, I think of them in 3 buckets. And they may in fact be about equal size in terms of that 45%. So 15, 15, 15. The first bucket is people who want a vaccine, but for whom they're not going to be able to jump through hoops or they don't want to jump through hoops. I have family members, cousins I talk to who I'm like, have you gotten vaccinated? And they're like, oh, I went on the website. It was painful. I had to put in my insurance information. You know what? I'll get to it at some point, maybe in May or June. So of course, like I'm actually now setting up appointments for them because that's crazy and I want them vaccinated because I need them protected. But people who are perfectly happy to get it, there's nothing hesitant about them. But those examples are people who don't want to jump through hoops. And there are other people who can't jump through hoops. That is a group we've got to figure out how to serve much more effectively. And that, of course, means getting more vaccines out to doctors' offices, which is why I was disappointed with the longer pause with J&J. And I'm hoping that J&J will get on pause relatively soon because J&J vaccines are great for physicians. You're seeing somebody in the office and you say, hey, want a COVID shot? We'll just give it to you now and you're one and done. I think that kind of convenience, walk-ins into CVS and Walgreens, going out into the community and really vaccinating people who can't come, going to work sites and vaccinating people. We have to have a ground game now for that next 15%. The second bucket of 15% are not people who are vaccine hesitant or resistors, but they're people with questions, people who, I talk to all the time who will say, these vaccines were developed really fast. How do we know about the long-term safety? What about these blood clots? And those people need their issues addressed. They do not need to be called vaccine resistors and anti-vaxxers, and we've got to deal with it. Those are good questions. How were these vaccines developed so fast? And that is a place where I think physicians are going to play an essential role, because it's one thing to hear it from some guy on TV. It's very different to hear about these things and the safety of these things when you hear it from your own physician. And I think physicians, obviously other trusted health professionals too, I don't mean to just talk about docs, but physicians are going to play a central role in this, not just on the one-on-one clinical encounter, but also being spokespeople in your community, talking to local media, but talking to at town halls, other things physicians can do to drive vaccinations in that group. That's 30% between those 2 buckets. And if we can get most of those, we're into the 80s among adults. that's awesome. And that's where things really start getting dramatically better. There is another 15% that's pretty hesitant, that may be pretty resistant. And that group needs engagement and conversation, but in my mind, it's a very different set of challenges. And again, I want to engage those people, but we may not be able to get a lot of them shifted, but that's okay. All of this is in my way of saying, if we do our job right, once we get into May, June, certainly by the time we get into summer, we should be in really terrific shape in the United States in terms of infections, with very, very low levels of infections, high level of population immunity. I think that'll make an enormous difference. And I am looking forward to a pretty good fall and winter. I do think there'll be some ongoing challenges. We'll see some outbreaks, but overall things should be pretty much closer to the fall of 2021 should look much more like the fall of 2019 than it does the fall of 2020. That's my hope, and I think there's reason to believe that that's possible. All sorts of implications for when can we have large group gatherings, when could we do a meeting like this in person, we can talk about those. I do want to take just 3 minutes to talk about the global picture, because America is not an island unto itself, and globally things are really quite bad. Right now, we're probably in the worst days of the pandemic globally. Certainly the worst days of the pandemic in India, where yesterday there were close to 300,000 new infections. But given their positivity rate, I believe that there were probably closer to 1 million new infections just yesterday in India. They only captured about 30% of them because their testing is wholly inadequate for the problem at hand. In Delhi, the capital, most hospitals are out of oxygen. It is a catastrophe what is happening. The FT has a story out today that says that the 2,000 daily deaths that India is recording may be an underestimate by a factor of 10. I don't know if that's right, but what I know is that just you have many, many thousands of people dying every day across India. And there's a whole set of factors that have gotten us there. India's vaccination programs are going very slowly. We really need a twofold strategy on the global front. And I've been talking to folks in the Biden administration who are deeply, deeply concerned about all of this. Obviously, these countries, India, Brazil, but there are many others that are going through a difficult time, need help on just virus control, standard public health stuff, more testing, more pushing towards getting better mask wearing, higher quality masks, all the stuff you and I, we've all been talking about for the last year. But we really do need to double down on our global vaccination efforts. And there's a lot of work and a lot of subtlety there, a lot of which I'm happy to get into in the discussion. You know, I think the next few months are just going to be very hard from a global point of view. And I remain deeply worried about where the world is. Obviously, if we get our act together, we get these infections under control, if we can build up global vaccination capacity, it's not a money problem, it's mostly a vaccine production problem. If we can build up vaccine productions, we can get a good chunk of the world vaccinated by the end of this year. I am on the more optimistic side of global vaccination time frames. I believe that we're going to have a majority of the world vaccinated by Q1, maybe Q2 of next year. There are people who think it's going to drag into 2023 or even 2024. I don't think so. I think we're going to need the leadership of the Biden administration. And one of the things I've been pushing them in private conversations is to not use the Trump administration's global strategy as a comparison, because that's a low bar. I think the Trump administration did a pretty poor job of engaging with the global community. Just doing better than that isn't good enough. You really need global leadership, and there is no other country that's going to be able to substantially ramp up global production of vaccines or drive that process, except for the United States. WHO can't do it by itself. The Europeans are not going to do it by themselves. They'll come along, they'll help, they'll be important, but you need leadership, and that's the United States. So that's what I am counting on, looking for, hopeful about, but we are not done with this pandemic. And in some ways, in many places, we're in some of the toughest days. Do think we're in a better place in the United States. And as we finish up the spring and get into summer, we'll be in a much, much better place. But we got to keep an eye on the global scene because, again, we're not alone in this. Last point I want to make, thinking back on the year since I had the opportunity to spend time with you, a lot has happened. In many ways, things have gone much worse than I think many of us hoped. In many ways, things have gone much better. And if you had told me a year ago we would have 3 highly effective, very safe vaccines authorized, widely distributed 200 million doses into people's arms, 130 million Americans vaccinated, I would have said, you're kidding, that you're really being very optimistic. So it's been fabulous. I think that's really been good. One of the things that has really caught me off guard over the last year, I don't think I appreciated this a year ago, is the role of misinformation and disinformation. How well organized it is, how concerted it is not random. And I have thought a lot about how do we counter that, because it has so undermined the global response, but also the US response to this pandemic. And one of the things that you keep coming back to, keep hearing about, and you heard this from Dr. Nunez-Smith as well, is it's about trusted voices. That at the end of the day, the messenger matters more than the message. And I don't know of any group of messengers overall. I mean, there are a lot of important messengers, religious leaders, civil society leaders, but I don't know overall a group of messengers that is more trusted than nurses and physicians. And so we really have to think about our voice for bringing this pandemic to an end, for preparing for future ones, and really engaging with the public on these issues. And so I know many of you and many societies, I think, have done a fabulous job on this, and I am grateful for that. And I think we all have to keep going. So I could keep rambling. I'm going to stop and say thank you again for having me back. And I look forward to a conversation, questions, discussion.
Thank you, Dr. Jha, for a fabulous, wonderful talk as usual. And thank you for all of your leadership during this past over 1 year. I've read a lot around how the global health effects of climate change are driving zoonoses and rewriting disease algorithms. In fact, I read a recent statistic that by 2060, 60% of the world will be at risk for dengue. So I was hoping you could say a few words to the audience about that.
Sure. Yeah, it's interesting. When a few years ago, when I was still at Harvard and working at the Global Health Institute and trying to think about what are the major priorities that universities need to be working on, and went through a process, the two that really emerged as the obvious two big global public health challenges of the 21st century, and they're related to each other, were pandemics and climate change. And they're, of course, as I said, they're linked. Climate change is the big public health challenge of our times over the next decade, 2 decades. And climate change is insidious. You don't look at a specific event and say that's climate change. I mean, sometimes you can, but climate change, the military has a really interesting term for climate change. They describe it as the ultimate threat multiplier. That whatever threats existed, whatever challenges existed, it multiplies those. For those of you who are more statistically minded, I think of it as an effect modifier, as an interaction term, right? Like it changes all the relationships that we think about. So climate change will be felt by most people, not through sea level rises or temperature changes. It will be felt through the health effects. And that's why I think many of us talk about many of us talk about health as the human face of climate change, that it is really how people will feel climate change. And how will that show up? You've already talked about the effects on disease vectors, which are going to change. We're going to have mass migration. Climate-related migration was already starting to take off before this pandemic. Just at the end of 2019, there were more people displaced than at any time since World War II, and a large chunk of that was climate-related famines and other things that are causing migration. Large migration has huge health effects for those populations and for everybody else. Big effect on nutritional content of food. It's just, there's a whole long list of ways in which climate shapes things. Our country, our infrastructure, one of the things I have been very worried about is our healthcare infrastructure is completely not ready for the massive weather events that are happening because of climate change. I still think about the fact that in most hospitals, guess where the generators are kept? In the basement, which is possibly the worst place, because with more 100-year floods happening every 5 or 10 years, like you knock off the electrical grid and you knock out the generators at once. Most healthcare systems have not thought about climate proofing. So there's a lot of work to be done globally, but there's a lot of work to be done locally as well. to get ourselves ready for climate change, which is not coming, it is here.
That's
You
great.
brought up the issue of infrastructure. We've heard a lot about infrastructure that you can see, but of course that connection of the public health system in the community to those clinicians on the front line, and how, you have 45 different medical society folks here. How do we work together to shore up that infrastructure so that we don't repeat this the next time?
That's a really good question. As a practicing physician who also obviously spends a lot of time thinking about public health, it has always felt really natural to me that there be really strong ties between the healthcare system and the public health system. I think we all know they're not the same. And in the minds of a lot of politicians and the public, sometimes they confuse them and say, oh, it's all health. We understand that there are divisions. But we've got to make those linkages much tighter. And it shows up in our clinical practice. We all understand as clinicians, right, that what happens in the community has a profound effect on who shows up in clinic with what symptoms, what medicines they're able to take, what their lives are going to be like. So it's not like the clinical practice is divorced from the public health architecture. There's some specific areas where I think we should be doing much more. I want to see, and this is going to sound a little bit narrow, but I think it's really important. We're going to see a much greater data integration between the public health infrastructure and the clinical practice. We've done a great job over the last decade investing in health information technology. We can talk about how usable and great the electronic health records are, probably a different conversation. But we've got a largely digital infrastructure now in the healthcare system, which I think is real progress. We've got to tie that in much more with public health. Because it's actually what's going to allow us to manage patients in a different payment model. One of the things that's very clear in my mind is, and this will tie to public health, is, this was a very odd year we just had for all sorts of reasons. One of which was we had the greatest health crisis in a century, and yet healthcare delivery systems, many of them, got financially really beaten up. And this doesn't make sense to people, except if you understand the underlying payment models and what do we pay for and how do we pay for elective procedures versus not, and how do we pay for visits. And and of course, everybody here understands those issues. When we think about it, we say, it completely makes sense. From a policy point of view, we've been on a journey towards alternative payment models, population-based payments. Everything that I understand about the world makes me think all that journey is about to get dramatically escalated. And we are going to be moving towards a different payment models much more aggressively. Well, if you are now managing a population, you really want to be connected to the public health infrastructure because A, it's the right thing. It lets you take better care of your patients. It probably will save you money. So that relationship is changing. And in my mind, again, I'm biased because I feel like I live both sides of the house. I think the two sides of the house coming together is going to make a huge difference for the health of our patients and of our communities.
And we lift up the whole foundation of healthcare when we do that. So
Yeah.
Thank you. I think Dr. Burston is going to ask some of the questions that have come in through the chat.
Great. Thank you so much, Ashish. And I think you and I have talked a lot about, for example, the role of our registries and thinking about different approaches and data infrastructure. And I think just, remarkable efforts around connecting to public health that are ongoing and need to accelerate. There was a question in the chat specifically related to a question you raised around vaccine hesitancy, and in particular, what is our role around helping to combat misinformation? So, for example, lots of concerns about vaccine-related deaths, for example. What's the role of us? And I think you did a great job pointing out our role individually as both a clinician as well as spokesperson, but more broadly, how can we help combat the misinformation that's still out there?
Yeah, I actually would love ideas from all of you. I do think the way people understand information. Again, the sheer amount of misinformation that's on social media, for instance, that I have to constantly fight the temptation to try to counter because I'll end up probably just amplifying it. I think the key issues are, in my mind, societies should be very out front and center, talking about the vaccines and how useful they are. The benefit that they provide, right, in terms of allowing people to live more safely, get their lives back. Obviously, one of the things I have tried to do on a much more personal level is talk about my own personal experience, the fact that I've been vaccinated, that my spouse is now vaccinated, my elderly parents are vaccinated. People want to hear folks they respect and ask the question, what have you done for your own family, for yourself? So I'd love to see more of the leaders in these specialty societies that were here talk openly and personally about personal decisions that people have made and why. And I think that's very powerful. But and then there's a lot of efforts happening across the country. There's quite a bit of money in the recovery in the American Rescue Plan for combating vaccine hesitancy. And basically, nonprofit organizations can apply for them, especially if you're partnering with community-based organizations. And as long as you're working on these things. So I want to just see all of us much more deeply engaged in this kind of work, almost in any way that we can. And sometimes it's just the simple conversations with our friends and family. And a lot of times it's media, putting out statements, telling stories about why these things are so important.
Those are really great points. Words matter, and we can change one mind at a time. I think critical to the societies here, one of the big emphasis in our statement last week was that the pause on the J&J was because of the success of the vaccine alert system and the CDC. And we can't express that enough. And just giving people that sense of, well, if you vaccinate 10 million people at baseline, you would expect X number of strokes and heart attacks and new diagnoses of cancer. But that temporal relationship of the vaccine, unfortunately, people, don't understand the risk benefit sometimes. And it's really important for us to be clear about that. I believe Dr. Bill Thorworth, who is the CEO of the American College of Radiology, has a question for us. Bill, can you tell us your question? If not, his question was, with the disproportionate impact of COVID. Oh,
he's here.
Bill, are you on?
Yeah, thanks very much. I appreciate
Great.
it, Darren. And Ashish, thank you so much for a terrific presentation. And my question is, with the disproportionate impact on minority communities, as we've seen, and it represents and I think has laid bare the healthcare disparities that underlie this, are you aware of specific efforts by leaders and, as you described, the messengers in those communities to get out and to combat this disinformation?
Yeah, I am, Bill. And actually, it's really nice to, again, start off this morning with Marcella, because she's been certainly spearheading some of this from a national point of view. There are a lot of efforts happening, again, a lot of efforts, but probably not enough. We need to be doing more. But a lot of efforts happening with entities, even academics, public health people, folks from my school, for instance, working with Black churches in Georgia, and at least that's where folks in my school are working, but other people working with community and faith-based leaders. I think that's really important. They've got great organizations like Oak Street Health in Chicago that is just doing fabulous work. And part of it is, here's the key thing, right? You can't establish relationships on a dime. Relationships are longstanding, and you've got to work with people who've been there. So people often say, like, we showed up with our van and offered vaccines, and 2/3 of people said no. Well, yeah, you've never been there before. No one has any idea who you are. You show up in a van with vaccines, you're not going to be shocked that a lot of people are going to be like, I don't know who you are. I don't know what brings you here, but you're not putting that in my arm. That is not an unreasonable response that a lot of people are going to have. So what people are realizing is, if you're going to show up into a community, you have to bring along people that folks know and they trust, who've been there for a long time. And so that kind of stuff is starting to happen, but I still hear those stories of, oh, there's so much hesitancy. And I think it's not hesitancy, it's access and it's trust. And it's not lack of trust in the vaccines, it's lack of trust of who's showing up and what they're trying to offer. And so we've really got to do a lot more on that. So there are efforts, but not enough on this.
I think our next question is from Dr. Saul Levin, who is the CEO of the American Psychiatric Association. Saul, would you like to ask the question live?
Sure.
Saul, you're on mute.
Thank you
Thank
very much. Thank you, Dr. Jha. Great presentation, again, educational, and also answers a lot of questions, at least for myself. So here's a small detail as my staff begin to return to the office. And this is the most common question I get asked by when I go out in public and give talks, and people are going to bring their staff back. The staff is still worried about the vaccine and coming into work. They believe that I should only let those that are immunized or vaccinated come back into work. As the staff begins to return to the workplace, having been at home for over a year, how would you handle those that do not or will not get the vaccine and return to the workplace where the majority of the staff will be vaccinated?
Wait, this was supposed to be a small question, Dr. Levin? Is that right? I'm going to push back on that characterization. No, this is a fundamentally hard question. And I've been talking to companies. Actually, we've been having this discussion at Brown about what are we going to do about. We've already decided we're going to have students require student vaccination. And I think Bowdoin is the first college that's actually come out and said they're going to require staff and faculty as well. So first and foremost, obviously the easiest thing if you want to have a really safe work environment is to require that everybody be vaccinated. And we're starting to see now, I think Houston Methodist just did this last week. We're starting to see more hospitals say, we require flu vaccines, and again, everybody handles this a little differently, but I'm a VA physician and I've always been required to get a flu vaccine. I've been told if I don't show up with one, that I can't step on campus, that my privileges get suspended. So if we can do that with the flu vaccine, we could do that with COVID. So one strategy you could take, and again, you're gonna get pushback and it's not totally straightforward, but I think you can do it. You can just require it. And that obviously changes everything, because then if everybody's vaccinated, it's a very, very different work environment. If you have one or two unvaccinated people out of a large group, you probably are okay, but there's still some risk of them passing it to each other. Obviously, then you're interacting with patients, which has its own complexity. What people have been pushing for is if you're going to bring people back who are not vaccinated, they need to be wearing masks and they need to be doing some amount of social distancing. But then do you make everybody wear masks, or do you just make those people stand out and wear masks? That is not a straightforward answer. Making everybody wear masks because 2 people are not vaccinated or 4 people, right? That's got its challenges. Just making the unvaccinated people wear masks has its challenges, because everybody then knows who's not vaccinated. So I wish I had a simple answer outside of, if there's any way you can get to requiring it, that will make an enormous difference. If not, if it's a very small number and infection numbers in the community are very, very low, you can probably get away without making everybody wear a mask, but you're just now treading into more risky categories.
Thank you. I think this is really fraught and very, very complicated. And these are fabulous vaccines. Nonetheless, there are some folks, such as people that are on immunosuppressives, and maybe some folks who just don't have that immune activation, who may not achieve appropriate antibody levels, even if vaccinated. And I do think it has been really interesting to see the drops in all types of respiratory infections. I believe the statistic was 1 death, a pediatric death in the US from influenza this past season. So we may all be wearing masks a lot more in large groups moving forward. One question did come in around what your thoughts are around boosters for COVID and where we're going to be with that in the future.
Yeah, it's a really good question. And last week, the CEO of Pfizer, I think, got a little bit of people kind of, I don't know, worried is not the right word, but just a little stir over saying people may need boosters as early as 6 months from now. I want to talk a little bit about what we know about boosters and my best assessment. And I'm confident people on this call who are more expert on this than I am, but my best read of things. So my sense is you need boosters for one of 2 reasons, and obviously they're related. But one is waning immunity. We don't know how long immunity lasts from the vaccines, and the second is variants. And if the vaccines really start showing more and more breakthrough infections from some of the variants, then we're going to want to do a booster targeting those variants. And of course, those two things are not totally unrelated, and there may be some overlap. My best guess, as I have spoken to immunologists, looked at the data, is these vaccines are going to last us a while. They're certainly going to last us at least a year. And so for the first couple of years, we may be in a situation where we're getting a booster once a year, but that to me feels about what I do with the flu vaccine anyway. So I don't see that. If it starts becoming every 6 months, that's more of a problem, but I don't see any reasons to believe that we'll have waning immunity from these vaccines at 6 months. So I think they last us at least a year. There's a lot of scientific work that needs to be done to figure out exactly how long. We need better data on what are the correlates of immunity. We really need to track breakthrough infections because of waning immunity. But all the data 6 months in look fabulous, and I think we're at least a year out in terms of boosters. On the issue of variants, it's far less clear. I mean, my take is that right now, our vaccines, and I'm just thinking about the 3 that we have authorized in the United States, all of them are holding up really well against all the variants that are out there, including 1351, the one from South Africa, which probably has the greatest amount of immune escape. We will see some breakthrough infections. We've not seen any evidence. And again, Israel is probably one of the best examples because they've done such a good job and they've got really good data. Yeah, there were some breakthrough infections, but not very many, and almost none after the second shot. No evidence that the breakthrough infection led to ongoing transmission, meaning there were some people who had breakthrough infections, they didn't get particularly sick, and they didn't infect anyone else. All right, well, that sounds okay. And so if that's where it holds up, then I think we're pretty good for a year. And, you know, I got the Moderna vaccine. I got fully vaccinated in February. I can imagine next February, March, needing another booster, and I'm okay with that. So that's my mental model. Obviously, things can change if variants change or if new data emerges. But I worry that we talk a lot about boosters, and then we're also trying to convince people to get their first shot, and they're like, oh my God, am I signing up for a lifelong every 6 months? And people are not generally. I think just going through that first course is going to make a huge difference.
Yeah.
And we may get longer than a year. We may very well get much longer than a year of protection.
So you're also with an audience that had to make some very rapid pivots last March and close down meetings, convert them to virtual meetings. And, you know, we have a lot of questions, and a big discussion point with our members has been around the return to face-to-face large scientific meetings for our societies. So what do you think?
There are 2 aspects of that. There is the public health response, and then there's the psychological response. And I'm going to try my best to handle both. And you know, it's interesting. I was having a discussion around what fall semester will look like at Brown University. And we were talking about if everybody's vaccinated, can we have in-person classrooms of 25, 30 with people not wearing masks? And I was like, yeah, probably. I mean, we don't have to. And then somebody said, well, we're about 200. And all of a sudden I got uncomfortable. There's not necessarily any reason to think that if everybody in the room is vaccinated, infection numbers are very low in the community, that you can't have a gathering of 200. It just psychologically feels much, much harder for me. But like, I can't come up with why we can't have a scientific meeting with hundreds of people in a room. You know, and I'm thinking also, can we have hundreds of people in the room and not be socially distanced? I mean, maybe my guess is a lot of people are going to continue wearing masks. It's not the biggest deal if you're in a large auditorium to ask people to do that, but will you require it? I think having large meetings where 30% of people are not vaccinated, that's going to be a problem. You can't do that. So decision points are going to be, if we bring back scientific meetings in person, are you going to require that everybody be vaccinated? And if the answer is yes, how are you going to verify people's vaccinations? And that gets us going down the road of vaccine passports, vaccine certificates. How are we going to manage that? And if you do that, I think we're going to have to do this step by step. It's sort of like there's a psychological reacclimation here that is hard. And my sense is that as the first set of meetings, maybe we'll throw in a little bit of antigen testing and make sure that, like, when people are coming back, everybody's testing negative. That'll offer us assurance that we can really do this. You know, I think the notion of a vaccinated person spreading it to another vaccinated person and either of them getting particularly ill or causing a large outbreak among vaccinated populations is so incredibly unlikely that like we will have to make that plunge at some point, but we're probably going to do it with some safety rails because I don't know, like again, psychologically, I have a hard time wrapping my brain around
Yeah.
being in a
Yeah,
room with
it's a
300
tough call.
unvaccinated, 300 unmasked people. Sorry, go ahead.
Yeah.
Well,
Yeah, well, I
probably
mean, we'll see.
3,000 more likely for some
Yeah.
of
Or
our
1,000,
issues, right?
or
Exactly.
1,000,
Yeah.
or thousands. Like it's just
Yeah, and-
psychologically hard.
Right. And certainly what we know is that the numbers I'm seeing are 0.008% risk. And even then the disease is very attenuated and much milder, et cetera. I think our last question, which is a great question, actually comes from Salam Wubu, who is the actual director for ACP's Center for Quality, and she's been helping to oversee our efforts at the college. Salam, would you like to ask your question live?
Sure, thank you, Daryl. And so I was wondering what some of the key messages we should focus on communicating following recent J&J safety concerns. And in thinking about J&J, which was targeted due to sort of logistical reasons towards some more vulnerable populations, and they were already concerned it was the less effective vaccine. Now that they're concerned it's not safe, how do we make sure that they don't feel that they're being targeted with a subpar vaccine? And can we be mindful about feeding into sort of this history of medical racism and narratives and concerns? It sort of feeds and plays right into that. So how do we combat that, especially if clinicians are the trusted messengers? They got the early vaccine supply; those were the mRNA vaccines. So how can they confidently say the J&J vaccine is safe? What strategies can we use to address that?
Yeah, no, this is a huge issue. And this is why, as much as I was supportive of the initial pause, I worried about the prolonged pause that we're in now. And I really hope that on Friday, the ACIP meeting, the ACIP group recommends unpausing. I mean, again, I think, on one hand, I made the point that, Daryl and you made that this shows the system working. But that's still pretty tough sell for a lot of people. And I think this issue of J&J being a subpar vaccine, of course, from a pure biological, immunological point of view, I think this is actually quite a fabulous vaccine. And there's a case that you can make that it's every bit as good, if not better, than the mRNA vaccines. I generally don't go around making that case because I feel like they're just three terrific vaccines. And I don't necessarily need to get into one is better than the other. Not sure that's a useful conversation, but we do need to. So how do you do this? I think first of all, you got to try to give people choices. People should always have the opportunity, and especially now with so much mRNA vaccines available, that people should be able to get Moderna or Pfizer if they don't want to get the J&J. I think that's absolutely critical. There are a lot of very prominent people, public health experts, who've gotten the J&J. And, we have a lot of us who are clinicians might have gone early and gotten Moderna or Pfizer, but then a lot of our spouses and friends have gotten J&J. And so highlighting that, right? And saying like, I understand, but like, my spouse got J&J and reminding people that we feel comfortable in our lives doing it. But it's a complicated situation. And if the pause lasts much longer, I just worry that it'll become much more complicated. And, Salam, as you said, there are populations for whom this is really ideal. I just think about homeless people. I think about people who are, I was literally hearing about this community of migrant farm workers where you go out and to the clinics, you help people address their health issues, and they're pretty mobile. And the idea of like, here's your Moderna and come back in 4 weeks, it's unrealistic and it's just not going to work, and people aren't going to. So I worry a lot about losing our ability to give J&J to people, but I also worry a lot about exactly the issues you raised, that the sense that somehow the most vulnerable people for whom this is a particularly helpful vaccine because it's convenient and easy is going to be a group that is going to feel like we're giving them second grade stuff, which it isn't. And I think, again, telling those stories of people who've gotten it, who have chosen it, despite the fact that they had alternatives.
Yeah, I mean, what I've told patients and neighbors and friends and family members is the best vaccine is the one you can get. And if the J&J had been the one that was available to me first, that's the one that I would have taken without
Absolutely.
hesitation. And I think
Absolutely.
that the other data that 16% of folks with COVID disease get blood clots, and that the risk of cerebral venous sinus thrombosis is 34 times greater with the disease. You know, again, we just need to continue to push back with the facts, one person at a time.
Yeah.
Well, you know, Ashish, this has been wonderful. I really want to thank you for your time and wondered whether there were any final words you had for the audience.
Yeah, only to say I really do think that in a remarkably difficult year, I think the medical community has been one of the true sort of standouts, the highlights of the last year, both in sort of the heroic work of frontline clinicians, ICU doctors, ER physicians, obviously treating COVID, but also I think the broader medical community in how it has continued providing care for very complicated sick patients without COVID in this context. So I am, first of all, I want to start off by saying thank you to all your members and all of you for helping get our country through this. Second is we've got to continue being the voice of science because we are among the most trusted people in society. We've got to keep talking about public health. We've got to keep talking about what it's going to take our country to get through this. We are, I think, as much as I feel like we're in a precarious moment right now, it's not 6 months down the road that things will start getting meaningfully better. It's weeks from now, we're going to start seeing real turning of the corner. Thank goodness. And then the last point is, this is a global pandemic, so we got to continue to be voices for a global strategy. You know, look, there are a lot of very, very good people in the Biden administration who want to do the right thing. Politics is complicated. Part of what our job is to create the political space for doing the right thing. And I don't mean getting politically involved in one bill or another, but to talk about the importance of things that are important, that are the right things to do. It actually helps policymakers do those things because we're creating the kind of underlying current and will to do it. So we've got to be voices for global vaccinations and global equity as much as we are voices for keeping Americans safe.
Well, thank you. Thank you so very much for your time, your expertise, and your leadership. Helen.
No, thank you again, Ashish. This is always a pleasure to have you back. And I hope we can have you back next year and we won't talk about COVID, which would be
That'd be awesome.
Let's
We'll
talk
do it in
about
person.
public health and data integration and really exciting. So thank you so much, Ashish. So, and Darylyn, of course. And for those of you who are continuing with us, our professional peer group meetings, the CEO Council meetings begin at 10:30 Eastern time. So thanks again, and we'll see you all soon. Bye.